this is not the second team. So this is the first team that we have today. So we're really pleased today to have Pam Gillam. Pam is the director of the Center for Health Services Policy Research. Is that?
And Policy Research.
And Policy Research. So it's associated with the HSPM department, and she is an expert in quality improvement. So that's the topic today. For the first hour, we'll be talking about quality improvement. Now, it appears elsewhere on your syllabus, but we have to grab important, busy people like Pam when we can get them. And so for the second part of this, we'll be doing the lecture on motivation, which completes all the material that you'll need for your midterm. And so remind me to discuss all of the ins and outs of the midterm, as well as the exercise number 2, which is closely associated with the topics that we'll be going over today in terms of motivation and leadership. So we'll do that later on after Pam concludes her session. So you have 4 graded exercises. You've done 1 on the value chain. The next one is coming up. I think we agreed the late 11:59 p.m. on the 21st of October. It has to be in, or you all turn into pumpkins. And so that's on Blackboard. We'll talk more about that. That's about leadership and motivation. The 4th exercise is about quality improvement. Specifically 2 techniques. So we're teaching you about stuff, how to do stuff in this course, and 2 techniques that will be really useful: Ishikawa or Fishbone diagrams and Pareto charts. And so Pam will be talking about quality improvement in general, quality improvement as opposed to quality assurance, and then specifically teaching you about those 2 techniques. So I want you, those of you that have your textbooks, and Lauren's going to do an overhead shot of case study 2, the Carbondale Clinic. So that's the case that we're generally talking about today, not specifically, but generally. And to do that case, you'll have to know about Fishbone diagrams and Pareto charts, which Pam is talking about today. And I also have some YouTube videos that are pretty good on those topics. So pay attention, because this is most of what you're going to get in terms of those 2 techniques that you'll use for that last exercise. So ask any questions that you might have. And again, we're really fortunate to have Pam today, and I'm going to turn it over to her right now.
Thanks, Mike. Good afternoon. I'm Pam Gillam. I'm the director of the Center for Health Services and Policy Research. I do think I have become kind of the on-campus resident expert in quality improvement on the public health side. Probably also located on that side, I'm sure there are some business folks as well. Have any of you heard me talk about QI before? Okay, good, because I covered a lot of the same stuff. How many of you are MHA students? None. Health IT students? Okay, MPH students. Most of you. Okay, good. MPH? I'm sorry. All right, good. So I like to know that because it helps in terms of thinking about examples to share with you. Most of my work in quality improvement has been more in the public health sector. I've worked a lot with DHEC and their clinics. I've worked a lot with some of our nonprofit organizations across the state in terms of looking at childhood obesity. I've done a lot in terms of home visiting programs in our state, looking at oral health, tobacco cessation, home visiting programs as it relates to children's health outcomes. So I'll be using some of those examples. I was excited to see your case study today. I've actually done some work in terms of looking at wait times in areas. I'll touch upon a little bit about that. But as Dr. Bird said, we'll be covering the Fishbone diagram and the Pareto principle / Pareto chart. today, which is part of your assignment. So after the class, y'all should go do that real quick so you don't forget what you learned. All right, so we're going to talk about quality improvement in general. I'm going to talk to you about Institute for Healthcare Improvement. How many of you heard about that organization? Okay, good. Just a few. I hope that by the end of your program, you become very familiar with IHI, even if it's on your own, okay? Because the work in terms of healthcare and quality improvement, they're the good go-to organization for you. Talk about that. Just touch upon Lean Six Sigma and, Lean and Six Sigma as two quality improvement methodologies, talk to you about the IHI model, and then go into the diagram and the Pareto chart. So why should you care about quality improvement? Well, if you're interested in being a health educator, and many of you are MPHers, that's kind of where I generally put you in that category. Quality improvement is a great approach for implementing evidence-based practices. Okay, and so thinking about how you test changes or evidence-based practices on a very small scale, do it using the IHI's model for improvement is a great way to do it. Okay, if you're interested in being a researcher like me, well, first of all, evaluation is required of every federal grant that you write. Okay. And quality improvement is becoming more and more on the forefront. Evaluation and quality improvement fit very nicely with one another. And you're seeing researchers use quality improvement to complement evaluation. Because it's not so much anymore about were we faithful to the program or to the plan that we set out. It's how do we measure our program that we set out on a regular basis consistently to make sure it's working. Because if it's not working, you don't want to spend 2 years doing a program that doesn't work, right? You want to look and test changes to it to see if you can improve it on the way, okay? And there's a lot of research out there that's being funded that way. And then if you're interested in administration, from a health IT perspective, I will tell you, hospitals are using quality improvement. Reimbursements beginning to depend on it, and many organizations are in desperate need for it. And IT plays a huge role in terms of process improvement. Data collection is a big, big piece. So, if we keep saying maybe something magical happened and we'll just see some change, then we're not going to see any improvements in health outcomes. We really have to spend some time thinking about how do we implement or test on a small scale so it doesn't use up too much of our resources, but how do we start doing business differently to improve health outcomes? I know you guys have talked a lot about in terms of U.S. healthcare system, and we're seeing some dramatic changes happen, right, with the Affordable Care Act. And so it's how do we look at that process, how do we identify our processes and measure them so that we make sure that they're reaching our goals in terms of improving access to care. So what is quality? So American Society for Quality is a nonprofit organization, huge organization that defines it as the characteristics of a product or service that bear on its ability to satisfy the need or satisfy the stated or implied needs, okay? Believe it or not, you are always providing a product or a service, okay? Regardless of what you're doing, if you are a health educator and you are working in teen pregnancy prevention, you're going to be offering a service, okay? And it's probably going to be an evidence-based model that they've shown that's reduced teen pregnancy rates, and the activities that you do within that model is the service that you're providing, okay? A couple of other names. Philip Crosby defines it as conformance to requirements. That's more focused on quality assurance side. And then Joseph Duran, who came up with the term Pareto principle, and we'll talk more about that in a minute, talks about fitness for use. It's all about how do we use things the most efficiently and effective way that we can. How do we provide services? How do we provide the best products, okay, to meet needs? All right. Edwards Deming is kind of considered the father of quality and quality improvement, and he talks about quality as a never-ending cycle of continuous improvement. Have you heard the term PDSA cycles or PDCA cycles? The word cycle in and of itself implies it's never ending, okay? If you talk to people who do quality improvement and they tell you that they ran one PDSA cycle, then they're not doing quality improvement, because quality improvement is testing over and over and over again and measuring and checking over and over again to make sure you're on the right path. So in terms of thinking about the quality journey, it really did start kind of in the manufacturing industry, and it was really focused on that conformance to standards, quality assurance, okay? It was all about, we need to make sure that we are meeting minimum standards and hitting the mark every time. And if we're not, who's to blame? Who can we point fingers at? What point? Then it started moving towards quality improvement. The key difference between quality assurance and quality improvement is quality improvement focuses on the system, okay? It's kind of let's measure the big picture and identify where the errors are. It could potentially be a person, but it's probably, if it is a person, it's more likely related to training of the person, not the person themselves. And then we've moved to rapid cycle quality improvement. The whole idea of how can we collect information, just enough information, quickly and look at it, even if it's hour by hour, minute by minute, to see what do we need to do to make sure that we're meeting our standards. So I'll give you an example. In New Mexico, they have a technology-based system that they developed that the supervisor uses. And the supervisor, it's in a Medicaid, SNAP, and TANF office. SNAP is food stamps. TANF is a financial assistance program for needy families. That supervisor can be in the back room, but can be monitoring where people who are coming in to apply for benefits are in the line, okay? Because there's different phases that they go through, different steps in the process. And he or she can tell immediately where there are bottlenecks, where is there a long waiting line, and they have standards for each step in terms of how long people should be in each step of the process. So that supervisor can manage their people by moving them around to work at different steps based on that information that's provided to them, okay? That's data, right? That's a technology system. And that's the whole idea behind rapid cycle quality improvement, okay? It's focused on knowing where you are and figuring out ways to get things better. And the most important thing about quality improvement is it specifically attempts, it's very deliberate and purposeful to avoid attributing blame, okay? It's all about not pointing fingers. That's one of the big things about quality improvement. If I'm in a conversation with somebody and we're talking about this and they start talking to me about needing to find out who the problem is or start talking about staff performance, they're not talking about quality improvement. And it's very much focused on creating systems to prevent errors from happening, okay? So dummy proofing. You know when you go online and you are booking a flight? How many of you done that? Most of us, okay? You know when the little red blinking light goes on, alert, you forgot to fill out this field? That's the whole idea behind dummy proofing, okay? That's what we're talking about there. So the key differences between quality assurance and quality improvement. Quality assurance, as I mentioned, is focused on, are we meeting the minimum standard? Okay, quality improvement, the whole quality improvement, a big piece of it is that mindset. It's we're always trying to do better, improve performance. We know where we currently are, and we're trying to improve from that. Quality assurance is typically retrospective, meaning I'm an auditor for an organization. I come in and in the hospital and I pull charts because I want to look to see if you're completing the charts correctly or filling out certain things that's supposed to be in there. Is every sheet for a discharge or everything that was supposed to be done for a discharge in there? Okay. Quality improvement is it's more prospective. It's thinking about where do we want to make changes. It's constantly being done. QI, typically in a culture of QI within an organization, everybody has some level of training and quality improvement. You're constantly collecting data and looking at it as a group. You don't have just, it's not a separate function or department within an organization. It's infiltrated throughout. And then, as I mentioned before, quality improvement is really focused on the big picture, the system, okay, and process improvement. It's not about pointing fingers. And it's continuous. It's not time limited. So those are the key differences between quality assurance and quality improvement. Okay, so I know that Dr. Bird did not tell you this, but you have a quiz. You have to get these questions correctly or you get knocked a letter grade, so y'all better do well. I'm joking, guys. You can laugh. Okay, quality assurance, QA or QI, quality improvement. Y'all tell me. Which staff member failed to transfer the call to the correct extension, QA or QI? QA. QA, okay? I want to point fingers. I want to find out who did it incorrectly. Are we creating an environment encouraging clinicians to report errors? QA or QI? QI. QI, okay? Because I'm focused on the system here, right? I want to know, why are clinicians not reporting errors? If it's important for me to know those errors, I've got to figure out how I can get clinicians to report that information. How do we reduce billing errors by our staff? QA or QI? QI. Okay? I want to know, what kind of billing errors are we making? Is it in a specific step of the process? Did I write crappy instructions? Do I need to improve on my instructions? Are we not training our staff well in terms of how to fill out the paperwork? Okay? Do we see that all of the errors are occurring within the first, or not after they've completed the paperwork, but somewhere else? Or is it a specific code that people are confused on what to use? That's what I'm talking about in terms of quality improvement. We want to collect that kind of information and look at it. Patient had a bad outcome. Were the doctors or nurses at fault? QA. I want to point the fingers at the nurse or the doctor. And then lastly, what could we do to increase the efficiency of chart filing? QI. If you see the word efficiency, you can pretty much bet it's quality improvement. All right. Quality improvement is always about the customer. Okay? The customer may not always be the patient. Sometimes the physicians. Sometimes the government. You have to define who your customers are. But sometimes, as an organization or a business, we have to say, you know what? That customer is right, and I cannot meet their needs for whatever reason. That is not a smart business move on my part to be able to try to provide those types of services because it may cost me too much money. I might not be able to do it well as someone else. You know, the competition is too great. So the idea is here is with quality improvement, it's always about the customer. Now in public health, that's really hard because, number one, lots of people don't have very strong feelings about people who use public health services, right? And don't necessarily feel that we should have to worry about customer service because we're handing out payouts, right? That's how some people's attitudes are. Now, we really need to think about that. And then also in public health, as I mentioned before, we have other customers we have to deal with too, right? Like government, all kinds of constituents beyond just the people we might be serving directly. All right, so quality alphabets. Oh, go ahead.
I'm just wondering if there's ever a time when it's more appropriate to focus on quality assurance than quality improvement, or is it just always better to go for quality improvement?
Very good question. To me, from my training, quality assurance is actually part of quality improvement and not vice versa. So in Lean Six Sigma or Six Sigma, there's a methodology called DMAIC, Define, Measure, Analyze, Improve, Control. It's actually I thought I have it up here. Yep, the colorful one. See it, the blue circle? It has the 6 sigma in the middle of it. So control is that step. is that quality assurance function. It's to ensure, with Six Sigma, you're talking about reducing variation, and I'll talk more about that in a second. We want to be able to do the same thing every time. Okay? I want to park my car in my parking lot, or my parking lot. Or I want to park there, here we go, I'll change my example. I want to park in between the white lines perfectly every time, okay? Or I want to pull into my garage and I want to make sure my green tennis ball hits, have you ever seen that where people pull into their garage and have the tennis ball hanging so they make sure they don't go too far? That's kind of that quality assurance. I want to meet that standard every time. But the difference is you want to make sure you're meeting, every time you're meeting the same standards, but you need to be collecting data to know, am I not doing that anymore? Is my controls that have been put into place not working anymore? And why are they not working? Okay? So that was a very good question. So going back, DMAIC, I talked to you about that Six Sigma. It's about reducing variation. I'll talk more about that in a minute. Lean is focused on time, efficiency. Okay, so you've got Six Sigma. That's more of the quality, the variation, reducing variation. Speed is also a quality, because think about wait times in clinics. They care about that, right? So speed, efficiency. Those are both very, very important. So my training was in both, quality and efficiency. The Plan, Do, Check, Act, and the Model for Improvement, which are pretty much the same. The Model for Improvement came out of the IHI model. I'll talk about that more in a minute. So those are words that you might hear a lot. PDCA, PDSA, Model for Improvement, Six Sigma, Lean, Business Process Reengineering. You still do hear that when you're looking at your model. So I'll give you an example. Department of Health and Human Services, who is our state Medicaid agency, is currently, they have had a case management model in terms of determining eligibility for people who apply for Medicaid. Okay? A case management model means you come in, you apply for Medicaid, and someone is given your case. They are assigned your case to process. Well, the number of people in our country that are qualifying for Medicaid, number one, because of our economy, and number two, with the Affordable Care Act, is going to go up. But resources to staff handling the number of cases that are going to be coming in is staying the same pretty much. So they are changing their business process model to be more of a process management model, where they're going to have people work by function, by step, versus being responsible for a particular case, which from an efficiency standpoint and a quality standpoint is the better way to go, to be more of a process management model. So somebody will come in and apply. There'll be a person there who will intake the application. They'll have certain tasks that they have to do associated with intake. Then they pass it on to the next person who is going to be in processing. That person will have certain steps that they have to take as it relates to processing. That make sense? Okay. Another thing to understand about quality improvement. Quality improvement is not just top down, it is also bottoms up. And this is really, really important, especially with the Institute for Healthcare Improvement's Breakthrough Series collaborative model, which is their quality improvement method. You have to have leadership support and commitment to quality improvement. They have to be willing to, for staff to collect data, to look at systems, to use that information, to test changes, to make changes. They have to be on board. With that being said, your direct service staff who live it and breathe it every single day, they also know what's going to work and what doesn't work. Okay? And so it's really important in quality improvement to engage them as well to help you work through the process. It also helps to have direct service staff on board because they also are really important in terms of getting buy-in and support for changes you want to test and implement. So that's another big piece of quality improvement. From a quality assurance standpoint, that can be pretty top-down. I have minimum standards I expect you to make. I do your annual review. I'm going to tell you whether you made them or not. From a quality improvement standpoint, we're focused on the systems here. I need to make sure our system's working the most effectively and efficient way possible. I need you to help me figure that out. All right, so as I mentioned, three models for quality improvement, just to go over those really quickly. There's Six Sigma, as I mentioned to you, that's really focused on reducing variation. I'm going to be able to do the exact same thing every time and get the exact same results. DMAIC is the methodology: define, measure, analyze, improve, control. Those are the 5 phases. And you'll hear CPK, process capability. How stable is my process? How capable is my current process to make sure that I hit it on the nail every single time? Lean is really focused more on identifying the value added. Have you heard that term? Value added steps. And the value added steps are defined by the customer. You also hear them called as customer requirements. Okay, what does my customer care about? Do you think my customer cares about my billing office in the back? No, they care about their wait times. Okay, do they care about charting? And no, they care about you seeing them quickly and providing good customer service to them and getting them what they need. In Lean, you'll see process maps. Have any of you ever seen a flow chart or a process map where it's each step? Process maps are huge in using Lean. And I will tell you, process maps, for me personally in quality improvement, anytime you're doing quality improvement, that is a great place to start. Okay? And then the IHI Breakthrough Series, the model for improvement. It's really focused on improving through small scale testing. Okay? You use the IHI model over the Breakthrough or over Lean Six Sigma when you already know what to do. It's great for testing evidence-based practices in your own setting or promising practices. Lean Six Sigma or Six Sigma or Lean are really good tools to use and a methodology to use when you don't know the answer. Okay, that's how I like to differentiate between the two. You use the model for improvement when you know what to do, when there's a clear gap between what your practice is and what the evidence is out there. So for example, the 2A's plus R, which is what we call the tobacco cessation intervention in our state, at the national level it's called the 5A's. It is an evidence-based practice to reduce tobacco use. Okay, so they use that. It was modified in our state, and we've had our family planning and WIC clinics within DHEC test how they would implement that evidence-based practice in their clinics, in their clinical settings. Another example of model for improvement in terms of using what you know works and testing in your environment. They're really big on it doesn't have to have come out of the healthcare setting to use. So, for example, you've seen checklists. You've heard about checklists for surgical checklists or discharge checklists. That came from the airline industry. I mean, the pilots have to complete checklists before they take off. And that's what they did and found that it reduced errors significantly. Well, that's the same concept, right? Two totally different industries, but same concept. So something you'll notice about, and at the bottom I like you to know, even though these are 3 different methods, they have a lot in common across all 3 of them. One of them is you need to understand how your process flows. That's where process mapping comes in handy. You need to understand your overall goal and strategy of operations. You don't go and start doing quality improvement activities until you know why you're doing them. Okay? What's your goal? Importance of the voice of the customer is critical across all 3 methods. You've got to have leadership and organizational buy-in. That means top-down and bottoms-up. And there is a strong need for data and measurement. I will tell you that Lean and Six Sigma are very data rigorous methods, okay? They're into confidence intervals, p-values, all of those. The IHI model thinks measurement is important, but you're going to be okay with just looking at more of your descriptive statistics. Now, I was just over at Palmetto Health recently, and I was actually talking to the head of their ER operations. This was before my daughter broke her arm, and she laid there for 5 hours with a broken arm before the orthopedist came down to fix it. So talk about process improvement issues they're dealing with right now in that area. But he said to me, Lean Six Sigma is overboard. This was his opinion now, not the hospital's opinion, but this is what he said directly to me. He feels that you can get just as much value of understanding descriptive statistics. Do you know what descriptive statistics is? You will know it when I tell you. Do you know what it Health IT guy? Okay. Average, mean, median, mode, range. You know what I'm talking about now. You learned it in statistics. Those are the ones you want to make sure you're really proficient in. And teams. All three models use teams. Okay? And those teams, they have different names, like you have a champion, and you have a process owner, and a project sponsor. You have all these different names of the people who participate on your teams. But that's really, really important. You have people from different areas, not just your leadership, but you have direct service staff participating. Any questions so far? Okay. Institute for Healthcare Improvement. They're a nonprofit organization based out of Cambridge, Massachusetts. One of our Department of Health and Human Services administrators who's now running for governor in Massachusetts, Don Berwick, was the founder of this organization. And they are really focused on the triple aim. This is about improving the health of the population, enhancing the patient care experience, so the quality of the patient care that we're providing, improving health outcomes, and doing it in a way that's cost effective. Okay? So you can go on IHI's website, it's IHI.org, and you'll see a lot of that they've done on an international basis in terms of running what they call Breakthrough Series collaboratives on different issues in terms of improving health outcomes. So the IHI Breakthrough Series is a quality improvement methodology that's about taking an evidence-based practice, something that you know that works elsewhere, so it's existing knowledge, right? And adapting it to the setting within which you work to accomplish a goal. That's what it is in and of itself. This is what it looks like. So basically, you have a planning phase, which is over to the far left side in terms of selecting a topic. You're bringing in your experts who know what the best practices are and how it works. You form teams who participate, and you present to them through these training sessions called learning sessions in the content. Okay, what is it that what practice is it that you want them to take back and test back in their settings? And then they're trained in quality improvement, specifically the model for improvement. I'll show that to you in a second. That's what LS1, LS2, and LS3 are. Those are learning sessions. They're basically training sessions. So they get trained in content and quality improvement. Then you see where it says AP1, AP2, AP3. That's where the teams go back to where they work. And those are called the action periods. That's where the fun happens, where they test on a small scale these different ideas or hunches or theories or best practices that are given to them to test. So to talk to you about what we did at DHEC, I worked with the tobacco division, the Division of Tobacco Prevention and Control. They wanted to roll out a policy there to require their clinics to provide the 2As plus R, which is an evidence-based practice to reduce tobacco use rates. They got some pushback from the local health departments because they were like, you know what, we don't have time. We've got so many other things that we have to do and other standards we have to meet. We can't add this to our list. Well, partly because of the pushback, they asked us to come in and run an IHI model. And we worked with 7 clinics across 2 regions. They were WIC, which is Women, Infants, and Children's, program and family planning clinics. And we worked with them to figure out the how, which is the what, here's the practice. Now you use quality improvement methods to test how you would roll that change out in your clinics, okay? And so we trained them in the 2A's plus R, so they were trained in how to do the 2A's plus R. Then we trained them in the model for improvement, which is this, and how to test on a small scale using PDSA cycles. They went back to their clinics. They tested their ideas that they had using of how they thought they could do the 2A's plus R. We provided different supports to them, like site visits and where we would go and talk to them about their changes that they were testing and help them modify them or work with them on other ideas. And then they collected data to see what worked. So before we started all of this, you know how I told you there was pushback from the directors at the local level? They were like, it takes too much time. So we had these clinics collect some data. What do you think, if it's going to take them too much time, meaning they're worried it's going to increase the wait times for their current clients, they already have high caseloads, you know, how are we going to be able to add this to one more thing that we need to do with each client? What do you think one of the questions we might ask? We're talking about tobacco use here. What would be a good question? How many of your patients come in a day and say that they smoke or use tobacco, other tobacco items? Okay, that's the first question you want to know is, does everybody come in and say they're smokers? Well, what we found is maybe a quarter per day of the total number that come in a day identify themselves as smokers. Okay, so you've already reduced, let's say 40 come in a day. I'm really bad at math. 10 people come in and identify themselves as smokers. All right, so then it's ask, advise, refer. I've asked you if you've smoked. You told me yes. I advise you that smoking is bad for your health. You know, here are what the causes are from smoking, blah, blah, blah. The referral. Can I refer you to the quit line, which is a 1-800 number. They will call you and provide you free counseling sessions based on your insurance. Okay? Are you interested? How many of those 10 people, which is 25% of our population, do you think accepted the referral? Do you think all 10 did it? Heck no. Not in South Carolina. So we're talking about lower numbers, right? So we're talking about, they found, you know, that maybe half would actually accept the referral the first time around. So what we were able to share back with them is, you're not adding a lot of time to your day because of the number of people who are coming in on a daily basis, identifying themselves as tobacco users. We also tested how much time it took for them to actually complete the referral form. So we had them collect how long it took them to fill out the paperwork. It's a one-page document. They have to put the client's name, address, you know, phone number. You know what they ended up doing? They have patient chart tabs. They were able to pull a tab off and phew, put it right on there. So that reduced their time even more. So we're talking maybe 3 to 5 minutes, if that, if they don't have the labels. Or if they have the labels, it might be even less to actually do the 2A's plus R. So they didn't see a significant impact on their efficiency of their current clinic processes to do the 2A's plus R. Does that make sense? Okay. So the model for improvement is the quality improvement methodology that's pushed by IHI through their collaborative series model. And to me, it is probably the most relevant one that we use in the work that we do in the healthcare. Okay, Lean Six Sigma is great, but this to me is probably more appropriate, especially as we have promising practices and evidence-based models out there. First, we need to ask. Go ahead.
I just had a question. Were you getting pushback from your local level department heads not because of the time, but because of just changes that were being made that they didn't feel comfortable with?
Well, they certainly did not say that.
Right. When we first they said it was because of time, but How do you work with an organization to get that like buy-in that we've been talking about?
Okay, so quality of culture is, trying to instill the culture of quality is really huge. And really, anytime we make any changes, we need to pay attention to the impact it has on our stakeholders, right? Those that are going to be affected by it. And so, to me, the IHI model allows you to engage the people that are not normally engaged in change. And I think that can make a huge difference. Cotter's change, did you talk about Cotter in this class?
Not yet.
Okay. You're going to talk about John Cotter's change management. Kind of there's like 6 steps of change. You've got to, I'm not going to be able to say all of them to you off the top of my head, but one of them is being able to explain to them, articulate to them why the change is needed. Why is it really, really important? Secondly, you need to communicate with them of what changes you're talking about and get feedback from them on their concerns. And then you need to help address those concerns to try to make them more comfortable with the change that's about to occur. And then there's other steps. But basically it's about how do you engage staff that are going to be affected by this change and try to address their fears or concerns. It doesn't mean you don't do it because they're fearful, but you engage them. And I will tell you, and Mike may or may not agree with me, state agencies aren't really great about change management in their organizations. They oftentimes come up with the policy in their ivory white tower and then send out a memo and say, this is the big change and it's going to happen in a month. And the cool thing about the IHI Breakthrough Series model and doing the Tobacco Cessation Collaborative with DHEC was we engaged staff at the local level to really help figure this thing out. And they really influenced that policy before it was put out. Not only did they help influence the policy, but they were really smart in that they gave clinics, first of all, it ended up changing the policy based on what we learned from that collaborative, based on what was originally developed. And then secondly, they gave the regional departments plenty of time to make the change, to implement the change. They gave them like a year. So that's pretty big.
So Pam asked them the exam question, what 2 things do you get when you engage the staff at the lower levels in the organization in a change?
You want me to answer that or you want them to answer it?
I want you to ask them. They can hear me.
Okay, say that again.
So what 2 things do you get?
What 2 things do you get
when you engage staff
when you engage staff
in a change?
in a change? What 2 things do you get?
Buy-in.
Buy-in's 1. The other is equally important. Think about staff at a lower level in an organization.
Feedback. Satisfaction. Like,
Who knows how things are really done? The people at the top or the people at the bottom? So you get improved quality. Because the people at the top don't know what's going on. They don't know what changes need to be made. And so to really identify possible improvements, you need to involve the people who do it every day.
We had our teams for the DHEC Tobacco Cessation Collaborative, we had admin staff participate. They never get to participate in stuff like this. So that was pretty huge. So first you come up with your goal, then you identify your measures. So we talked about the measures. And then your measures to let you know whether or not you've made an improvement. So I want to see if I'm the family planning clinic director in Richland County and we've implemented the 2As plus R. I want to know of my tobacco users that we've identified and done the 2As plus R with, how many have actually quit smoking, right? That's an outcome measure. I want to know that. I also want to make sure that we're doing the 2As plus R correctly. Are my staff correctly providing the intervention? So that's going to require me to do some observation. Or check in my notes, do I have a way to collect that information? Those are process measures. And then I need to know the balance measure piece is by adding the 2 A's plus R, does that really increase the amount of time and reduce the number of patients I can see in a day? Which we found no. But that's called a balance measure. So those are the 3 types of measures you're looking at. And then what changes can we make that will result in improvement? That's the 2 A's plus R. Okay, those are the promising practices or really good ideas that you have or your staff have to try to test on a very small scale. And when I mean small scale, I mean let's go next Tuesday and test with one of our patients that comes in the 2 A's plus R and see how it goes. Hey, you know what? We need to change the referral form a little bit. This is something that we found when we did the collaborative. Can we change it just slightly to be able to collect the information more quickly? Or get more accurate information? Or do we even need to ask the patient? If they agree to it, can we just get the information in our system? So that's what I mean in terms of thinking about testing changes. And you do PDSA cycles, do you do them once or do you do them multiple times? Multiple times, right? Go ahead.
Yeah. Sometimes you can test the changes. It works, but how to test the sustainability?
The sustainability?
Yeah.
So you test over and over again and you continue to grow your numbers. So say I tested with just one patient and then I test the next week with 5 and then I test for 3 days all of the patients that come in and then I just keep testing. But remember, I'm also collecting the data in some efficient manner, either in my current database or a special database to look at, is it making a difference, right? Does that answer your question? Or am I all of a sudden seeing that we're seeing less patients, or our staff are or our patients are waiting longer? Would it have anything to do with doing the 2 A's plus R? I don't know, but I'm going to try to figure that out. Does that answer? Okay, good question. All right, so I've introduced you, I've talked about the differences between quality assurance and QI. You should be experts now. You should also be experts in Lean Six Sigma, and so you don't need to go get a green belt. I'm just kidding. I really recommend if you have the opportunity to go through some kind of certification for quality improvement, and Mike's been hearing me talk this for a long time, it will make you a stronger candidate for a job. I really do believe that in a healthcare setting. So if you have the opportunity, go do it. Some kind of certification. It doesn't have to be a green belt. IHI, you can go to do their training. There's certification in professional, or certification in professional and health quality or something like that. CPHQ is what it stands for. So let's talk about 2 different tools that you can use. The first one is the Pareto Chart. So interestingly enough, the Pareto Chart was a term that Joseph Duran came up with, and he named it after Vilfredo Pareto, who was an Italian economist who recognized that 80% of the land in Italy was owned by 20% of the population. He also realized that in his own garden that 80% of the peas came from 20% of the pea pods. Okay? So that's how this term of 80-20, the Pareto principle, came around. You also hear it called the also known as the 80-20 rule. The idea behind it is that 80% of the effects are associated with 20% of the causes. Okay? You use the Pareto chart when you're trying to prioritize your work, where you're going to focus your time. That was meant to come way before this. So it's about how do we identify the vital few, okay? There is no way you're going to be able to solve all problems. A lot of it's going to be just because of the organization within you work and how much control you have over the issue. But as an organization, it's important for you to collect that information and use it to prioritize your work. And so the example I have here, and I just realized that my slides are out of order. So at the bottom, you have your reasons, individual causes. Reason 1, reason 2, reason 3, 4, 5, 6, and 7. And you can do this in Excel, guys, okay? So these are your individual values. And then this line represents the cumulative percentage over time. And once you hit the 80% mark, this is 80%, this is 100. Ooh, I'm stepping out of the line. Once you hit the 80% mark, those are the areas you want to focus on. And so by looking at this chart, you can see that probably the first 3, maybe even just 2 reasons may be the ones that our organization decides to spend its time on trying to fix. Okay? Does that make sense? I meant to show you the fishbone diagram first because I think that's more important. But this is an example of a Pareto chart. So, Greenville Medicaid office. They have well, it's not just Medicaid. It's a county-owned office building that has a window for Medicaid and a window for SNAP and TANF. Okay? So we went up there to try. They have horrible, horrible waiting lines. Their waiting lines are so bad that fights have broken out between people who've been standing in the lines. The waiting lines, they also were concerned how long people waited. Not only did they have really long waiting lines, but how long people were waiting. And you would hear anecdotally from people that they were waiting for 2 hours. Okay? So we went to the office and they asked us to take a look at their lobby area. Were there improvements that they could make in their lobby area, but also figure out really how long are people waiting in line and why are they coming into their office? Okay? That's the big question, right? Waiting, by the way, waiting time is a symptom. It's never a root cause. Okay? So they were in the waiting room, and before we started the time study, it was really important that all the staff participated because I needed them to fill out these sheets, okay, that we were handing the people coming through the doors. Each person got a sheet for themselves or for whoever their family members were, basically their family that was walking through the door. And I asked them, I said, well, how many people do you think come in a day? They were like, a lot. Really? What's a lot? A lot. A lot of people come in our doors. 100? Yes. 150? Yes. Okay. So they don't know how many people walk through their doors in a day. We did 3 days of time studies. On the first day, they had over 450 people walk through their doors. Okay? Second day, it was around 435, and the third was like 384. And we did this throughout a month. It's not like we did it consecutive days. This lobby area is not that big, okay? The other thing we found out is we looked at the time of day they were coming in. Half of those people come in within the first 2 hours that they open their doors, which is 8 o'clock a.m., okay? So we're talking about 200 plus people coming into their lobby area walking in at some point within the first 2 hours of the day. So then we said, as part of that sheet, we had all of these different reasons why people came in. The number one reason why people came through the door was to find out the status of their application, okay? It wasn't because they needed to turn in documentation or verification. Yeah, there was some of that, but they just want to come in and find out their status. Well, why were they coming in to find out the status of their applications? Process was slow. Process was slow, but why?
There's no way to check online.
No way to check online. And no one answers the darn phone. That was really it. was they couldn't get anyone on the phone to give them something, even if it was, I can't tell you exactly why, but I can tell you it's still in pending status, okay? So you had people who were coming in, and they even told us anecdotally, the only reason why I'm here today is because I can't get anybody on the phone, okay? So they just want to know their status. So remember, the waiting room is just a symptom, okay? It's not the cause. The cause is located where? Can't get anyone on the phone, right? There aren't other opportunities for them to get in communication with agency. So, Pareto chart, as I mentioned, is good for prioritizing, and this is where I screwed up my slides. The first thing you really want to do is you want to do a fishbone diagram, okay? A fishbone diagram, a couple other names, the Ishikawa diagram or the cause and effect diagram. This is a great visual tool to help you see what the possible causes are that might be causing the problem, right? And have you ever seen these? So some of the benefits are it helps a team understand that there are multiple causes to a problem. Okay, it's a good graphical display, and it helps you identify areas for improvement. I recommend you do your fishbone first to get an idea of what the problems are. Like, for example, when we were working with the SNAP and TANF and Medicaid offices to find out why people came through the door, they helped us identify what the reasons were that they thought people were coming in through the door. And we had an other. So if for some reason it wasn't listed, we would put it under other. And then we collected the data on what we thought were the main reasons why people walked through the door to help us create a Pareto chart to show us what were the 20% causes causing 80% of the problems. Does that make sense? All right. So let me show you some examples. Anybody play basketball? Okay. Free throws. Problem is missed free throws. Okay. You have your problem statement is over here. This is where my problem is. Okay, that's the fish head. And then over here, there's the spine. You have these different lines that come out. This is why they call it a fishbone. And so what you'll see typically from the manufacturing industry, I'm not helping Miss Douglas very much because I'm going back and forth. You'll see materials, methods, equipment, environment, people or staff. Public health, you might see processes, policies, which is the same thing as method, people/staff, physical settings / environment, materials, kind of like your resources. What do you need? So if I did that, if this is free throws is my problem, okay? Had method here, or shooting mechanism as it says, material, the shooter, which is the people, and then the machine, the hoop in the background. So these are just examples. So you can see, what's my problem? I'm hitting 30% of my free throw shots. What's the problem with my method of delivery, right? Where I'm aiming, am I bending my knees? Do I have good balance? Okay, material, what did they say? Air pressure in the ball, size of the ball, the lopsidedness of it. Shooter, am I motivated? Am I concentrating? Okay, so do you get what I'm saying in terms of those are, and you keep doing that. Here's immunizations. They used people, process, IT documentation, and policy. And all of the lines, so when I say why is it that the free thrower is not making 33% of his shots? Or what is it about the ball, okay, that's causing me to only make 30% of my free throw shots? Does that make sense? So immunizations in a hospital, they were having a lot of people with the flu coming in, and so they wanted to address this issue of immunizations with those clients. So they would ask the same questions. You know, what are our policy and procedures around immunization? Do we have any? What is it? Do we have the resources that we need? Do we have enough flu shots in stock to immunize our patients who are coming in, who may come in with other illnesses, but we can ask them, have you had your flu shot this year, and provide them a flu shot while they're in our hands, okay? That's the whole idea. We're going to practice in just a minute. Here's another example. This was AIDS Education and Training Center that was looking at the problem of cancer screenings with, and they were looking at specifically in terms of low rate of pap smears. And so why is it that people are not, why are women not getting pap smears? Okay. And so they looked at procedures, environment, people, equipment, and those were the ones they focused on. All right, so we're going to play. Is there a dryer?
Razor right there.
Am I just blind?
Right in there.
Oh, fancy. All right. What do you want the problem to be? And I've already been told you can't use your case study example, so we can't do that one. What would be a good problem? Let's do STD rates. Woohoo! All right. I don't want to do STD rates. Let's do. I don't want to do STD rates. Come on, guys. Give me an example, not STD rates. I did teen pregnancy one time, and I said, why is teen pregnancy a problem? And people were like, really? Let's not go there. Come on.
Suicide.
Suicide rates. Okay. Okay, you gave us a really hard one. Well, we can try it. Let's start with people because that's the easiest one. So let's narrow it down. Suicide rates in teen males. Okay. Why are teen males committing suicide?
They don't express the emotion.
Okay, it's taboo to express their feelings, right? What else?
Hormonal changes in the body.
Hormonal changes.
Lack of accessibility to counseling.
Great. So that probably would go more under, let's put it over here under methods. And we can put it over here because part of the idea is when you cover an area, so if I put lack of access here, you want to identify ones that are popping up in multiple places. Does that make sense? So you keep asking the question why for each of these little arms that stick out. Because you may have this one here, but then you might have, I might ask you, why is it taboo to express their feelings? I might ask you that question. You give me 2 or 3 reasons why it's taboo to express their feelings.
the male is supposed to be strong.
Males, right, this whole historical piece, right, of the male is supposed to be the strong, dominant figure. Who doesn't do that? So this historical issue. Good. And mind you, I gave you a list of these, typically you would see are like processes, policies, people, environment. Those are good ones to start with. So when you're working on your case study, I would start with those, but it doesn't have to be, okay? So if I just asked you, you could have just told me suicide rates in teen males is high because of lack of access, and I have lack of access to help. And then I would say, why is there lack of access? Okay? And you might say, funding. Okay? And I could put, let's put resources up here. Because resources means pretty much anything. Might not have qualified, trained staff. Money. What are some other reasons why suicide rates might be high in teen males?
Okay.
What about easy access to get a gun? Or something like that?
I don't know.
Unemployment.
Go ahead, and then...
Depending on the country, in my country, male have more responsibility in the family.
They have more responsibilities?
Yeah. So they have more issues, mental issues, and more anxiety. Yeah.
So pressure from the responsibilities? You had a question in the pink shirt?
I was
Oh,
going to
you're going
add,
to just give an example?
would like methods be like lack of self-care? You know what I mean? Like, where would that fit?
It could fit under, when you mean lack of self-care, what do you mean?
Like tools to help reduce anxiety or to reduce stress.
Yeah.
Like
Breathing, guided
capacity.
imagery. Exactly.
Sure.
Yeah.
And you may have that here under people, but it might fall somewhere else too. Remember, you're looking for, it might fall in different places. Go ahead.
Can you talk about the labels of the different axes again? Because I'm a little bit confused.
Sure. So these are the common ones that you'll see. In public health, I changed it for you. So, like, I'm trying to think. I just did this with another group, and I'm trying to remember what we focused on. Let's do childhood obesity. Okay? Sorry to nix your suicide rates, but that was just a kicker. And I'm less familiar with that topic. Okay, so always your child, just so you know, in terms of setting it up, your problem statement always is at the head, okay? And you draw your line, and you're going to have these different bones coming out from it, okay? Because this line, you could even put your problem statement in the line if you wanted. But typically, it's on the other side, it's in the head. So if we're talking about childhood obesity, let's not even focus too much on these areas unless you have one that fits. But tell me a reason. Why do we have childhood obesity?
Lack of activities.
Okay. Unnutritious?
Food
Is that a word?
Unhealthy diet.
Poor food choices at school. Or limited. Unnutritious. You got what I mean. What's another reason? Why are children obese?
Lack of activities.
Lack of physical activity.
See, I picked a great one.
That
So many ideas. Lack of physical activity. What else?
genetics.
Sometimes it's genetic.
Genetics.
Genetics. What was another one?
Technology.
Environment.
Genetics,
And sedentary.
technology, and environment. Okay? See how I did that? Y'all gave me 1, 2, 3, 4, 5. And then I'm going to come over to lack of physical activity. Why is there a lack of physical activity with children?
No PE.
No PE in schools. Okay? What else?
Instead of going for outdoor sports, they play inside, playing video games and all.
Okay. So, playing videos.
But could you tie that back to technology?
You're getting the idea, but start with one.
Okay.
Okay? That's the whole purpose of this, is that you start with one area. You start with these, and then you work just on that one. So you started with lack of physical activity, and we exhaust all the reasons for lack of physical activity. Then we move over to a different one. Poor food choices at school. We exhaust all of the reasons why there are poor choices of food. You could have told me funding is an issue. You could have told me lack of trained dietitians in a school. Okay? Those could be all different reasons. Let's go to technology. Video games. Why does technology why is that a problem?
Sedentarity.
Say that again, speak louder.
Sedentarity.
Sedentary.
Create people to be sedentary, good. Because the video games is like game choice, okay? You know, when you were younger, you played with sticks, which my kid could play with a cardboard box and be fine. But you're right, when they're exposed to videos, technology, that usually ends up becoming the choice, which creates them to be sedentary, right? These are sedentary games, I guess is a better way to say it. What else? What are other reasons? What is about environment?
Community parks.
Why are children obese? Because of the environment. What's the environment doing that's causing children to be obese?
Maybe it's not safe.
Might live in unsafe areas. Unsafe to play outside. What else?
Or there's lack of recreation areas and community parks.
Okay. Lack of recreation or community parks. Good. What else?
The food environment at home and school. The food.
Foods that are offered?
Yeah.
Okay, good.
At home and school and supermarket and the neighborhood and it's.
Yeah, they eat
Right.
outside.
So how many of you have seen Weight of the Nation? In Weight of the Nation, one of the things they talked about in the environment is in your poorest neighborhoods, you have like convenience stores that are on the corner and it costs $0.25 for a bag of chips and $1 for a banana. Okay, and then there's no closed food, there's no closed grocery stores. It's easier to walk into the convenience store and get food. So then you do this and you continue to exhaust. And as I said, okay, well, why is funding an issue? You might even have more of these, but don't kill yourself. You know, get as many as you can until you've exhausted. And then you start looking for patterns. Where are we saying the same thing over and over again? Okay? Now, something you need to pay attention to. You need to think about this in the context of what you're working in. So with the clinic, are they looking at it as a context of they're the staff in the clinic or the leadership in the clinic or both? Or
The leadership.
okay. Because you have to figure out what it is that you can address in terms of the problems. Okay? And so you may identify a few of these areas when you're looking at, is it waiting times? Is everything? Okay, you're going to be identifying the root causes of the waiting times. And then you want to measure what those root causes are, and you're going to be pretend measuring. Okay, so make up good numbers. And then you are going to have to figure out based on what you see is the 20%, the vital few for you to focus on as the leadership of the organization, what's in your control. So for example, the example that I showed you on the 100% immunizations, they had to basically say, okay, what is it that we have in control within our organization as it relates to immunizations, okay? We can't control everything that a person does, but we can control some things that occur here within our organization in terms of our policies and procedures. I can't force somebody to get a shot, right? But I can definitely ensure that we offer them a shot. So that's my point is, you need to think about it from the perspective of what is it that you can influence. So I love public health because, and I'm saying this jokingly, because we think we can fix it all. So when it comes to childhood obesity, I will tell you what you're seeing and as it relates to evidence-based practice is not a health education. It's not that health education isn't important, okay? But it's policy change. That's where we're seeing most effectiveness is focused on policy change, okay? So you need to think about it in the context within which you work. What is it that you can control? You're not going to try to address everything on here. You definitely want to get to the root causes, but then you have to ask yourself, based on that, based on what we know are the big issues, what is it that we can do as an organization? What is it? What are the resources that we have? What is it that we can do? Does that make sense? Okay, do you guys have a better sense of how to do this? 'Cause your question was about that piece. You don't have to do the materials, the methods, and you can go online, guys, and get all this. Just Google it. I'm not supposed to say that out loud in academic environment. Just Google it. Go ahead.
When you talk about people, I see staff in parentheses. Does people mean only staff, or
you might be talking about your patients, the people you serve. You may want to separate them and have their own lines, or you group them. I mean, I've seen examples where they group them. So if you're talking about your patients and your staff, I mean, or your internal stakeholders, your external stakeholders, you can call them that. Materials, that word doesn't resonate with me. It's more like resources, what are the things that you need to be able to do to get your job done, right? Policies and processes are oftentimes grouped together. Environment typically is kind of the physical setting. All right, so I'm going to be checking your grades. I'm going to be looking at your Fishbone diagrams and your... If you have questions about quality improvement, feel free to give me a buzz. I don't have any graduate assistantships available right now. Sorry. But I love talking about this stuff, and if you want examples or more have questions about specific other QI tools, feel free to give me a buzz.